Welcome back to Concepts to Clinics. Today's special is Iron Deficiency Anemia, IDA, Exam Gold. Dr. Joshi is here to take us from mugging facts to case-based learning in IDA.
Absolutely. IDA is anemia due to depleted body iron stores causing impaired hemoglobin synthesis, classically microcytic, hypochromic.
Why is IDA a big public health issue in India?
Because of high prevalence in children, adolescent girls and women. Its consequences are reduced work capacity, poorer cognition or school performance, increased maternal perinatal morbidity and mortality, hurts productivity, learning and survival.
Explain etiology mnemonic irons.
Correct. IRONS. I for inadequate intake and low bioavailability. Cereal, pulse-based diets with phytates or tannins, little heme iron, faulty waning, vegan diets without enhancers. R for requirement increased at infancy, adolescence, especially girls, pregnancy, lactation. O, output or losses, hookworm or Hellman's, menorrhagia, NSAIDs, hemorrhoids, repeated blood donation, etc. N for non-absorption, malabsorption, for example, celiac, irritable bowel syndrome, post-gastrectomy, achlorhydria, proton pump inhibitor use. S, sepsis and infections, inflammation, malaria, short interpregnancy interval, and poverty. And poor, WASH. It is water, sanitation, hygiene.
Case 1. 14-year-old schoolgirl on cereal pulse diet, tea with meals, heavy periods, poor sanitation. Which iron's elements applicable here?
Inadequate intake or bioavailability, increased requirement, output menorrhagia, WASH concerns that is possible Hellman's.
Please stage pathogenesis.
3 stages. Pre-latent where ferritin stores low, HB normal. Latent or iron-deficient erythropoiesis where transferrin saturation falls, and mild fall in MCV-MCH. Overt IDA stage, where microcytic hypochromic anemia with tissue hypoxia symptoms.
Clinical features, fast viva list please.
Symptoms are fatigue, pallor, exertional breathlessness, palpitations, headache, irritability, poor concentration. Signs are pallor, conjunctival nail bed, koilonychia, angular stomatitis, glossitis, brittle hair, pica, spoon nails. Tachycardia or flow murmurs. In children, there is poor growth, developmental delay. In adolescence, school underperformance. In pregnancy, there is higher risks, preterm, LBW, PPH, infections. Severe IDA may precipitate cardiac failure.
What about diagnosis? From screening to confirmation?
Screening is by HB estimation portable digital hemoglobinometers. WHO cutoffs for 6 to 59 months less than 11. For 5 to 11 years, less than 11.5. For 12 to 14 years and non-pregnant women, less than 12. For men, less than 13. And during pregnancy, less than 11. Severity, pregnancy and non-pregnancy, mild is 10 to 10.9. Moderate is 7 to 9.9. Severe is less than 7. Confirmation would be by peripheral smear. Microcytic, hypochromic with or without anisopoikilocytosis, increased RDW, serum ferritin low, but is acute phase corroborate with CRP. Transferrin saturation low, less than 15%, TIBC high, serum iron low. Soluble transferrin receptor increased, not affected by inflammation. Menzer index more than 13 favors iron deficiency over thalassemia trait. Always evaluate cause, that is stool for ova cysts or occult blood. Menstrual, GI history, deworming history, address causes like deworm, treat menorrhagia or GI loss, control malaria, improve WASH, and ensure birth spacing.
Case 2. A 28-week pregnant woman HB 8.2 grams per DL on PPI and can't tolerate oral iron. What now?
Okay. Under RMNCH plus A guidelines, moderate anemia 7 to 9.9 in late second or early third trimester with oral iron intolerance, then give parenteral iron at an appropriate facility. IV iron, sucrose or ferric carboxymaltose. After calculating total iron requirement. Blood transfusion is not indicated here. To reserve for severe anemia, that is HB less than 7, especially with cardiac compromise or obstetric emergency.
What about diet and counseling before treatment?
For all, there should be an increase in iron-rich foods, meat, fish, liver, that is heme, green leafy vegetables, amaranth or spinach, dal, chana, ragi, jaggery, that is non-heme. Also enhancers like vitamin C, lemon, amla, meat factor. Inhibitors are tea, coffee, calcium with iron-rich meals. Cooking in iron utensils help. Do address causes like deworm, treat menorrhagia or GI loss, control malaria, improve WASH, and ensure birth spacing.
What can be first-line therapy?
Okay, for oral iron, In children, elemental iron 3 to 6 milligrams per kg per day. In adults, 100 to 200 milligrams elemental iron per day in divided doses. While in pregnancy, treatment typically 120 milligrams iron plus 500 micrograms folic acid daily until HB normal, then continue to complete 180 days as per the guideline. Continue at least 3 months after HB normalization to replenish stores. For adherence, take between meals with citrus. If GI upset, then take after meals, or alternate day dosing for a GI upset. Also warn about black stools and constipation.
Please explain public health point of view, prevention and control.
Okay. Anemia Mukt Bharat under Poshan Abhiyan with the 6x6x6 strategy. 6 beneficiaries are 6 to 59 months, 5 to 9 years, adolescents 10 to 19, pregnant, lactating, all women of reproductive age. 6 interventions constitute prophylactic IFA, diurnal deworming, intensified BCC for diet and IFA compliance, anemia testing and treatment with digital methods, food fortification in public programs, address non-nutritional causes, malaria, fluorosis. Lastly, 6 enablers are interministerial coordination, National Anemia Mukt Bharat Unit, National Center of Excellence, convergence with other initiatives, strengthening supply chain, and digital dashboard for real-time monitoring.
Students mix up the IFA schedule. Any memory hack?
Okay. Syrup, blue, pink, red. So for 6 to 59 months, bi-weekly IFS syrup, 1 ml equals 20 milligrams iron plus 100 micrograms folic acid plus biannual deworming from 12 months. For 5 to 9 years, weekly IFA is blue, approximately 45 milligrams iron plus 400 micrograms folic acid. For adolescents 10 to 19 years, both sexes, weekly IFA blue is about 100 milligrams iron plus 500 micrograms folic acid plus deworming. For women of reproductive age, weekly IFA pink is 60 milligrams iron plus 500 micrograms folic acid. For pregnant and lactating women, daily IFA red is 60 milligrams iron plus 500 micrograms folic acid for 180 days during pregnancy and 180 days postpartum, that is prophylaxis. Students do write principle and frequency in exams.
What are the system-level enablers for AMB?
Routine screening of ANC, PNC at schools on VHNDs, line listing and follow-up, National Deworming Day February and August via schools, Anganwadis, food-based strategies, diet diversification, kitchen gardens, social and behavioral levels, menstrual hygiene management, delaying marriage or first pregnancy, spacing, girl education, strong monitoring of IFA stocks, HB testing coverage, severe anemia referrals and supply chain logistics.
Single most sensitive early lab test and the catch?
Serum ferritin is most sensitive early, but the catch is it rises with inflammation, so consider CRP or clinical context.
Case 3. 35-year-old male tea garden worker, fatigue, HB 6.6 grams per DL, pallor, hookworm endemic area. Priorities?
Severe anemia, so manage urgently. Start oral iron if stable, consider parenteral if intolerance or malabsorption. Deworm promptly, treat stool-positive helminths, diet with vitamin C enhancers, address wash, and plan follow-up HB. If cardiac failure signs or HB less than 5 grams per DL, consider transfusion with close monitoring.
Dr. Joshi, please close with exam boosters.
Okay, rapid fire. Cutoffs are pregnant less than 11, non-pregnant women 12, men 13, 6 to 59 months less than 11. Therapy duration is continue at least 3 months after HB normal. When severe in pregnancy, prefer parenteral iron. Transfuse only very severe or complicated. Key programs are AMB 6x6x6, weekly iron folic acid supplementation, National Deworming Day, food fortification and Poshan iron. Student, don't forget adherence tips, alternate day dosing for GI upset and that iron blackens stools.
That was Iron Deficiency Anemia. Clear cases and checkpoints. Thanks, Dr. Joshi. Listeners, rewind before exams and good luck.